Good afternoon, and welcome to today's New England Hymns webinar presented by our premier sponsor, Radial Analytics. AI-supported early mobilization of inpatients, a new approach to centralizing the right care at home. Presented by Dr. Anand Vasudevan, Chief Medical Officer at Radial, and Dr. Christopher Wellens, Senior Medical Director, Utilization Management at Maine Medical Center. Anand is the Chief Medical Officer at Radial and was part of the founding team. He leads Radial's clinical strategy, including clinical aspects of product and business development. He is a clinician innovator and has been involved in clinical translational and basic science research for the past 15 years. His primary career interests have been in combining technology with innovative workflows to facilitate sustainable and consistent delivery of high quality, cost effective care. He is joined by Dr. Christopher Wellens. Chris is the Senior Medical Director of Utilization Management at Maine Medical Center and runs the Physician Advisor Program that works for the entire Maine Health System. All lines have been muted upon entry today. Please send all questions via the Q&A box at the bottom of your screen. Please join me in welcoming Anand and Chris today.
Wonderful. Thank you so much for that introduction, and thanks to everyone on the line for joining today. We're really looking forward to our conversation. And as was just introduced, the title of our webinar is really around the use of AI to support both early mobilization and trying to centralize more of the right care at home. And I just wanted to encourage sort of at the outset that if there are any questions sort of along the way, feel free to pop them into the Q&A box, and we'd love to kind of address some of these questions as we go. And so with that, why don't we jump into some of the content that we have for you today? So the one thing I just wanted to mention actually at the outset is that I am a hospitalist at Brigham and Women's, and I'm on faculty at Harvard Medical School. But just as a brief disclosure, that all views that I'm expressing today are my own and really my capacity at Radial only. So as I'm sure those that are joining on the line might have seen on the website, we really have two primary learning objectives for today. The first is really kind of going back to the literature to get a better foundational understanding of the benefits of home-based post-acute care and the impact of early mobilization, as well as the relationship between early mobilization and trying to centralize more post-acute care at home. So we'll take you through the current literature around this just to build sort of that foundational understanding. And then for the second half of our webinar today, we'll get to a concrete example, which is really the partnership that Chris and I and Radial and Maine Health and Maine Medical Center more broadly have had around trying to facilitate more early mobilization. And there's really two components of this that I'd love for everyone to keep in mind as we're going through these slides. And those are delineated on the right side of the slide. So the first really is, what is the role of technology, of AI tools, in actually helping with things like patient identification and risk stratification? And secondly, on the right side, what is really the role of innovative workflows and point of care clinicians in actually operationalizing and intervening upon patients that tools can identify? We think that there's a lot of opportunity here, specifically when we're thinking about things like centralizing more of the right care at home. So a couple of background slides. So before we specifically talk about early mobilization in the inpatient setting, I wanted to take an opportunity to just zoom kind of way out. We're at this pretty interesting point in our healthcare system's evolution, where there are two sort of major trends that are going on. Well, there are many trends, but there are two trends that I'd like to highlight this morning. So the first is on the left, the fact that value-based care is accelerating, and this is generally a good thing, shifting care delivery more towards value. It's better for patients, for sustainability. But this is in the backdrop of some pretty challenging structural changes. We have an aging population. Seniors are living longer. We have an increasing burden of chronic illness. The number of patients, for example, with Alzheimer's is expected to double by 2050. And we have limited and finite, I should say, population health management and care management resources to manage these older and more chronically ill patients. At the same time, there's a trend that you see on the right side of the slide, which is that there's a growing ability to deliver healthcare at home. The simplest form of this, most common, really is home-based nursing, so home health agency providing skilled nursing services. There's end-of-life care at home, whether it's hospice at home or home-based palliative care. There are other outpatient modalities that have really accelerated, especially in the past 4 to 5 years, whether it's remote patient monitoring or telehealth. And there's emerging home-based care modalities that have been really sort of brewing over the past 5 or 10 years that are starting to gain a lot of steam when you think about things like home hospital or rehabilitation at home. And there's an interesting intersection really between these two trends. I think a lot of operators and those in the literature have been sort of asking the question, can centralizing more of the right care at home help with some of these challenges that we're facing structurally when it comes to an aging population, especially in a setting where we're thinking about appropriate assignment and utilization of resources, specifically in value-based care. In other words, which patients can and should take advantage of many of these emerging home-based care modalities? And this is where there's potentially an opportunity for technology, specifically AI-enabled interventions and other tools to help identify patients, to help bubble them up to the right point of care providers at the right time, and potentially improve quality and cost effectiveness of care. So with all that said, today what we're really going to do is focus on one aspect of this, which is really post-hospitalization care. And so we're thinking specifically about patients when they're leaving the hospital requiring rehabilitation and the choice that providers may have in setting up, for example, home-based skilled nursing services or sending patients, for example, to a skilled nursing facility. So let's start there, and then we'll work our way towards early mobilization over the next 2 slides. So the first point, sorry, that we wanted to make is really that there's a good amount of evidence around post-acute care at home benefiting the right patients. So a few points here. So for many common conditions, and these run between both medical and surgical diagnoses, seniors can achieve the same or better functional outcomes with skilled services at home following a hospitalization. This has been studied in joint replacements and heart failure, other medical conditions as well. The second point, which I think will feel somewhat intuitive, hopefully, is that facility-based post-acute care may be unnecessary or even harmful in some ways. There are a lot of risks in some ways at post-acute care facilities that are similar to being even in an acute care facility like a hospital. Think of secondary infections, delirium, venous thromboembolism. The specific reference that I have noted here, reference number 4, actually looks back. This is about 10 years ago, so things have started to change a little bit. An OIG report under the Department of Health and Human Services around different types of adverse events at facility-based post-acute care, and found that at that point, about a quarter of patients had some form of an adverse event, and many of those potentially could be preventable. More than half in that particular study. So there are risks, in other words, potentially of being discharged to a facility. At the same time, I would point to bullet point number 3 that there are some risks that have been documented in the literature of going home. There's readmissions data, and is one form of sort of outcomes measurements that's commonly used in this area. And there's one study that looked at, I think it was something like 17 million records of patients that were of Medicare patients and compared outcomes of patients discharged to home health versus skilled nursing facilities. And they used instrumental variable methods. And the translation of that, practical implication of that, is they were specifically trying to look at patients who were in this sort of ambiguous zone between requiring skilled nursing facility and home health. And when they looked at all comers, they actually, in the first study, which is reference number 5 here, noted that readmission rates were slightly higher for patients that went home with home health services as opposed to a skilled nursing facility. However, there have been many other studies that have been done in key subpopulations, including patients with dementia. And so there's an additional study that I'd point those that are listening to here today that looked at about 1 million patients with dementia. They also used instrumental variable methods. And in those studies, they actually showed very similar readmission rates between patients that went home and to skilled nursing facilities. So the translation here is that for specific populations, in other words, the right patients, as it says in the headline on the slide, there could be, the outcomes have been shown to be fairly similar. Mortality rates, point number four, have been similar in home versus facilities across many studies. And the final point, as we're actually thinking about value-based care, is that post-acute costs and costs within 60 days of admission are significantly lower for patients that go home with home health services as opposed to post-acute facilities. And that, hopefully feels fairly intuitive. It's really around the reduced sort of overhead and some of these outcome measures that have been stated here. So I'll move on to the next slide. So, you know, we've initially said that centralizing more care at home is a trend, and we've said that there are benefits specifically of thinking about home-based post-acute care after hospitalization. And now we're working our way backwards to actual mobilization in the hospital. So it turns out, as the headline says here, that mobilized inpatients are more likely to be discharged home. And I'll point to two studies. This is not meant to be comprehensive, but these are two sort of representative studies of different patient populations that have been studied. The first top study really looks at patients that are quite sick. They're critically ill patients in the intensive care unit. And this study looked at a couple of dozen randomized control trials of critically ill patients, meaning some of these patients were actually intubated, for example, they're mechanically ventilated at the time the study was done, who took part in early mobilization efforts, and discharge to home rates increased in 7 of these studies. It was statistically significant, as you see here. The second study looks at a much more generalized population, which I think is really generally our focus, for our conversation today. And this was a prospective study that looked at general medicine patients, and there's several studies that are similar to this, where they implemented a multidisciplinary mobility bundle. And so the key point here is sort of the multidisciplinary part, where they involve nurses and inpatient care teams and physical therapists, occupational therapists, and really worked on trying to coordinate care in the inpatient setting. And this similarly showed a decrease in discharge to rehabilitation facilities when this bundle was actually implemented amongst a general medicine population. So hopefully the takeaway at this point is that there could be benefits potentially to sending the right patients home with services after hospitalization, and early mobilization might be able to get more of the right patients home. So with that, I'll switch gears a little bit to really kind of zoom in on early mobilization and provide a little bit of background here as well. So I wanted to start with a common story. So this story, I think, would be familiar to those that have been part of the discharge planning process. It's really fairly commonly seen, but I'll quickly step through this. So imagine an 82-year-old that was hospitalized for a mild heart failure exacerbation. This patient's nurses and PTs recognize the importance of early mobilization to maintain functional status. And the challenge is that they've run into a bunch of competing priorities. The nursing workload is very high. The nurse taking care of this patient is also managing 4 other patients, for example. Therapists, physical therapists, occupational therapists, for example, have really been tasked with prioritizing discharge evaluations over participating in things like early mobilization. And with the increasing burden of chronic illness that we're talking about at the top of this webinar, there's there's a lot of urgent, higher acuity patients who take priority over interventions like early mobilization. And so the outcome at this point is that the patient became progressively deconditioned because they weren't able to be mobilized as much as would be ideal, and they suffered a complication. They actually developed pneumonia by day 7. The expected hospital stay of 4 days ballooned up to about 10 days, and she required discharge to a skilled nursing facility. And it's interesting to ask ourselves a question, really in the context of what we were just discussing, could we have improved this outcome by using a solution to help nurses and physical therapists prioritize the right patients for mobilization at the right time? And I think this is the kind of patient that we really have in mind when we're thinking about early mobilization initiatives and trying to prevent adverse outcomes with early mobilization. So as we discuss more about early mobilization, I just wanted to take a moment to sort of formalize what we're talking about here. So what is early mobilization? Here is a definition. And so one way to think about it is it's the practice of initiating movement and physical activity as soon as is medically appropriate typically within 24 to 48 hours of hospitalization or surgery. And this includes patients that are in the intensive care unit, as you saw in the previous study that I cited, to prevent complications and promote recovery and improve patient outcomes. And there's, this. I think the takeaway here is we just need to try to get more patients moving as soon as possible once they're in the hospital. But as you can see, even just in this definition, there are several areas of ambiguity. For example, when is a patient medically appropriate? What does it mean to really initiate movement, right? There's a decent difference between 24 hours versus 48 hours after hospitalization, right? So there's a lot of ambiguity just even in the definition of it and certainly in the implementation of early mobilization initiatives. So you can begin to see why this may not be quite as straightforward as just getting the patient moving as quickly as possible. Now, we talked a little bit about how early mobilization can help get more of the right patients home. There are several independent benefits of early mobilization that I wanted to highlight as well. So, in addition to the high likelihood of home discharge, early mobilization it has been shown to improve several physical health metrics. So, there's improved functional outcomes and enhanced recovery at steady state. So, patients are able to participate in their activities of daily living more consistently, more quickly, able to go back to their day-to-day lives. There's a reduced risk of adverse clinical outcomes as well. Reduced risk of deconditioning, which makes sense with mobilization and therapy. Reduced risk of venous thromboembolism. So these are clots that are caused by lack of movement. And even a reduced risk of hospital-acquired pneumonia. And as you recall in the patient's story that I had presented just a moment ago, that patient developed pneumonia on day set. There are clinical and operational benefits as well, reduced inpatient length of stay, a reduction in 30-day readmission rates. And there's a decent amount of literature that shows early mobilization improves emotional and social well-being of hospitalized patients, largely because patients sort of feel like they're being treated holistically. It feels like we're thinking about how they're going to return to day-to-day function once they actually recover, and not just the details of their acute medical care, um, which are important, but don't tell the entire story. Now, I wanted to provide a balanced perspective. There is some literature that suggests there could be risks of early mobilization, but I just wanted to point out at the outset here that the vast majority of studies, randomized controlled trials, national and international guidelines really suggest that the benefits of early mobilization significantly outweigh the risks. But for completeness, I did want to share this one study that reviewed 15 randomized controlled trials. This is across a few thousand patients. And it showed a few things. So the first is that it did show improved physical function. And this is based on patient-reported outcome measures. So the patients themselves were saying that I've returned to function in a way that is meaningful to me, right? Based on post-discharge surveys. There was no significant change in the actual hospitalization rate. So far, this actually looks pretty good, right? It doesn't look like much of a risk. But they looked at secondary outcomes, which are specifically adverse events, and they defined them as a decrease in oxygen levels, some cardiac arrhythmias, falls, and a few others that you see here. And in this particular study, they stated that they possibly increased, but there are a few limitations here. The authors acknowledged that only 5 out of 15 of these randomized control trials actually measured adverse events, so there's some selection bias here. There was one out of these 2,700 patients that were studied, there was a single 750 patient study that might have skewed the results. That 6-month outcomes, for example, are subject to things like survivor bias in patients with critical illness. And the final piece of this is that many of these patients actually had critical illness, right? And so these findings may or may not be generalizable to a general medical or general surgical population, as patients that already have critical illness are likely going to be more prone to many of these secondary adverse events. And so the take-home point here, I think, is very similar to what we were talking about earlier in this webinar around a possibility of increased readmission rates when patients are discharged home. When one is being more aggressive about trying to get patients home or to a care setting that's slightly less monitored, there is always some risk of that patient not being able to handle that less monitored care setting. And this is where a combination of potential risk stratification of taking an objective approach to figure out the right patients in whom to be aggressive, and then pairing that with the right kind of workflow really feels like an opportunity to take advantage of many of the benefits of interventions like early mobilization and mitigate the risks. So right now we're hopefully we're sort of at a point where we've sort of built the case that early mobilization is a good thing. Generally there are lots of benefits that patients can actually accrue. So what are the barriers to actually implementing this, to mobilizing patients in the inpatient setting? So there are a few different things that I could point to in the literature, but this particular study was pretty interesting. They employed a patient mobilization survey and surveyed 568 inpatient providers in 8 hospitals across a couple different states. This is in the West Coast of the United States, and they surveyed specifically physical therapists, occupational therapists, and nurses. And the goal here was to try to identify the top perceived barriers to mobilization. And so these are the top five. I'll quickly step through them. So the first is inadequate time, which makes sense. The inpatient setting is sort of busier than ever. Lack of understanding of when or how to refer to therapy staff, which is highly variable. Um, uh, Inadequate knowledge or inadequate comfort. Maybe knowledge is what they literally said in the study, but really they also mean sort of comfort of when it is safe to mobilize patients. A lack of confidence in the ability to mobilize patients, and the lack of training was also cited on how to safely do it. So not just when to safely do it, but how. And when you kind of look beyond just that one survey, other studies have also noted the following, that sort of unsurprisingly, training in mobilizing patients was highly correlated with confidence. So that sort of makes sense. Um, In many additional studies, PTs report more training and more confidence in mobilization as compared with other disciplines. And that also sort of makes sense as they have more formal training specifically when it comes to mobilization. And in multiple studies, the converse is also true, where RNs that are very commonly part of early mobilization programs expressed a little less comfort than PTs with mobilization, right? And the final point here is that it was really around patient family resistance to mobilization in the hospital. So there are a few studies that have bubbled this up, but there are also many other studies in the literature that suggest that patients and families really want to get up and moving, for the most part. Most patients are motivated to return to function. So I point all of these things out because it hopefully will shed some light and provide some intuition around number one, some perceived barriers. Number two, some opportunities around building confidence and building training and engaging different members of the inpatient care team around actually mobilizing patients and giving them sort of comfort and confidence in who they are actually intervening upon. And sort of thirdly, to sort of plant the seed that um, although that would be a good thing to achieve, it's not trivial, to actually achieve that, because we need to identify the right patients and equip the staff in sort of the right way. And so, although it's not totally trivial, there are some successful elements of early mobilization programs. If you look at many of these that have been implemented across the country, there's studies from across the world that look at many specific things that have been implemented. So I'll highlight a few things, and I think these will sort of resonate as we go through sort of the rest of the presentation. So the first is increasing multidisciplinary collaboration, particularly between those that are involved with mobilization. So we're talking about nurses and physical therapists and occupational therapists. One way to get around confidence and timing and figuring out when it's safe, as an example, is just to improve multidisciplinary communication, and not leave it all on one individual's shoulders to figure that out. The second is really around processes and algorithms to promote early and regular mobility. And this really goes back to the same theme that we've been repeating. How do we identify who to mobilize early? Ideally, we would mobilize everybody. But the timing is an important thing to make sure it's both sort of physically safe, that it matches up with availability of internal resources in the inpatient setting, and those sorts of things. So how do we do that? The third are really around role delineated protocols. And what this basically says, what this basically translates into is empowering individual clinicians in the inpatient setting, whether, for example, it's nurses, PTs, OTs, to feel like they can speak up and question orders such as bed rest, right, when it doesn't seem appropriate for the patient, and create sort of an environment of multidisciplinary collaboration where there's the opportunity to surface those kinds of things that can small things in some sense, in some cases that can make a big difference. And the final thing is sort of accurate monitoring and documentation. And so a key limitation that we currently have, even though many of these elements of early mobilization programs have been described and characterized is that there's a lack of a standard geriatric specific guideline for actually promoting mobility. And this is sort of a challenge that comes up again and again. So take a quick peek at the Q&A or chat. Any questions before we kind of start to segue a bit here? Okay, great. Please feel free to put some feel free to throw your questions in there at any point. Okay, great. So as we're moving towards the path forward here, so we've kind of established a lot of different benefits of early mobilization, some of the challenges with actually implementing early mobilization programs. The path forward could look something like this, right? A more standardized approach to identifying inpatients appropriate for early mobilization, leveraging an objective approach to prioritize patients appropriate for early mobilization. So let's say we've identified everyone as being appropriate for early mobilization. Where should we start such that it would be highest yield? And then the third concept really is this bridge between technology and workflow. How do we facilitate multidisciplinary workflows to identify which patients, for example, can be mobilized by a nurse, the patient's floor nurse, which patients really do require physical therapy evaluation or intervention, which patients could benefit from a more focused, intense PT plan, such as what Chris will talk about a little bit later in this talk. And so a key point here is could technology and specifically an AI supported solution help accomplish these goals? And so with that, I'm going to switch gears a little bit and tell you a little bit about Radial. So this is, we're now segueing to sort of learning objective number two, where we're talking a little bit about applications of AI and a concrete partnership between Radial and Maine Health, Maine Medical Center to see if technology can potentially facilitate early mobilization and getting more of the right patients home. So before I pass it over to Chris to talk a little bit more about that, I just wanted to give you a bit of a primer on the actual technology solution. And so we'll cover that in the next few slides. So just a brief introduction to Radial. We're a Boston-based health tech company. We have a heritage in NIH and NSF funding. And so we really pride ourselves in the clinical robustness and the statistical robustness that underlies our algorithms and that was born out of peer-reviewed research. And really our philosophy is to get the right patient, the right care at the right time. And the way in which we've done this, which I'll show you over the next couple of slides, is through next generation decision support to centralize more of the right care at home. And so specifically, we focus on integrating a variety of data sources, both longitudinal and real time. We facilitate real time decision making. We purposefully tried to provide insight on the part of those that are using our platform into what's driving our recommendations. So we translate statistical insights into plain clinical language to help drive consensus. And then we use all of this to enable more timely care coordination and more timely inpatient intervention, for example, things like early mobilization. And so our solutions and our areas of focus really run across a variety of different areas that have to do with centralizing care at home. And so these are our decision support modules as an example. So on the left side and on the bottom left, you see that we've focused on end-of-life care. So this is both palliative and hospice. How do we get more of the right patients who are hospitalized plugged into these at the right time? The placement module that you see here is really focused on post-acute care. And this will really be the focus of what I'll talk about in the next couple of slides. And that's really how do we identify the right patients to go home rather than to facility-based post-acute care? And there are a variety of clinical operational areas that we focus on as well, including social determinants of health, helping reduce readmissions, uh, for patients that do require a skilled nursing facility, helping optimize their length of stay there. And then finally identifying patients, for example, in an emergency department or other settings who might benefit from a 3-day waiver in the case of our partners that are in ACO arrangements. So this is sort of our overall approach to trying to centralize more of the right care at home. But I'm really going to zoom in on placement as our post-acute care module to give you a bit more information about how that actually functions. So the placement module is AI-supported risk stratification for next site of care, and this is next site post-hospitalization. And so to think about how this works, imagine that there are 3 patients that are currently admitted to the hospital. Some of these patients look like the patients in blue on the left, and there's no real uncertainty around the discharge plan for this patient. They will require a skilled nursing facility or inpatient rehab, and that's just the right decision for them. And there are other patients that look like the ones in orange on the right. And again, there's very little uncertainty. They should be able to go home or home with skilled services without much of a problem. And then there are patients that are sort of in the middle here. We call them on the border, and they're at risk, for example, of an unnecessary, facility-based post-acute stay. Typically represents something around like 15%, of patients that are currently admitted to the hospital. And what we tried to do is essentially identify these patients from the moment they actually come into the hospital. So this is day one of the hospitalization. And the idea is that by bubbling these patients up, starting on day one, we might be able to actually safely shift discharge dispositions in favor of home care, thereby reducing readmissions and hospital length of stay and total cost of care. And I think one of the things to sort of highlight is that across many places in which our platform is used, one of the key mechanisms for actually accomplishing this after the patient is bubbled up, starting on day one, has been to think about things like early mobilization. So that's the tie-in to our to the overall theme today. Really quickly, just to give you an overall sense, how do we identify these patients that are in the on the border category? Well, we do pretty robust clinical, functional, and social risk stratification. So just to give you a sense for what's in these domains. So thinking about clinical risk stratification, we look at the reason for a patient's current hospitalization, the acuity of that hospitalization, the need for prior facility-based post-acute care, how often patients actually follow up in the outpatient setting to ensure that they won't slip through the cracks and have appropriate follow-up, and other prior outcomes like readmissions. We look pretty extensively at functional status. So really, a lot of the metrics here are taken from validated indices that and the elements that have a high degree of predictive value have been sort of extracted from them. So you could think of traditional functional metrics, the CATS index, Barthel's, MDS. We've looked at and borrowed elements that have predictive value. We've also looked at a variety of frailty scores. There's one that's published in the Lancet that has a high degree of validity that not only takes into account functional status, but functional status as it relates to clinical comorbidities. So these are some examples of things that we look at when we're risk stratifying at a functional level. We also look for actual evidence of functional decline as the patient fallen or they had prolonged hospitalizations. Um, and then finally, admittedly, one of the most difficult ones is social risk stratification on the right-hand side. And here we really look at both environmental social risk and patient-specific social risk. And so we have access to public data sources where we actually help characterize the environmental risk. So you may have heard of the Area Deprivation Index. There's a Social Vulnerability Index that the CDC has created, and others where we're actually characterizing environmental risk. And then we look at specific evidence of sort of patient-specific social risk factors, many of which you see here. So when we combine all of these, we're able to really get pretty robust risk stratification to help figure out which patients fall into this middle category. And I'll just point out that these are just representative examples of data points that might fall into each of these categories, or it's in no way meant to be comprehensive. There's many hundreds that we look at here. And the final slide here before I pass it on to Chris is really where does all this data come from? We use a combination of claims data, so we get longitudinal context from a variety of different settings. We then have some real-time feeds, whether it's HL7 ADT feeds or in some cases some targeted electronic medical record integration. And then finally, as I was alluding to in the prior slide, we have a variety of sources to look at social determinants of health, both from publicly available data and also patient-specific data, thinking about things like Z codes. So I'll just take a quick peek at the chat here, see if there's any questions, and seeing none, I will pass the baton to Chris to tell you a bit more about Maine Health and our partnership.
Great. Thank you so much, Anant, and thanks for those who are listening in today. We're going to start off by just giving you a brief introduction to Maine Health. So we are an 8-hospital health system serving Maine and parts of New Hampshire. Recently, Maine Medical Center integrated with what some of you might know as Southern Maine Healthcare, and which is in Biddeford and Sanford. So that consolidation occurred in June of this year, and we are now a roughly 900-bed hospital, really providing services everywhere from kind of typical community hospital services to being a tertiary referral center. We're the only level 1 trauma center in the state of Maine. And the ACO that we participate with covers about 300,000 members. So, in terms of our sort of clinical and operational goals, certainly quality is very important to us, and Anant talked about some of the specific quality measures that are important to all hospitals. And at the same time, of course, we want to improve our throughput and reduce our inpatient length of stay, which we know is good for our patients. It's also good for as the only tertiary care referral hospital in the state. We want to have beds available for those who need the services that are really only we can provide in the state. And certainly we want to reduce readmissions. So it's great to understand the science and have these goals, but of course the environment is challenging. So in Maine, and I'm sure this is true in other places in New England, but certainly in Maine, the post-acute rehab bed availability is really highly constrained, and this was worse before the COVID pandemic, or bad before the COVID pandemic, and it is substantially worse since then because of facility closures and difficulty finding staff and all of the things that you folks are familiar with. We are going to spend a little bit of time talking about our enhanced therapy program, but the ability to staff that program is somewhat limited. And then this partnership with Radial is sort of based in our care management department. And of course, there's lots of competing priorities within care management. We're in a multi-year consultation with an external group now and trying to refine some of our processes. So of course, folks are getting pulled in a lot of different directions. But early mobilization is sort of a common thread for a lot of these things. And again, you've heard a nice review of the science. We feel, in addition, sort of particularly, that early mobilization can help to reduce falls and avoid the development of pressure injuries. And certainly, as has already been reflected, shortening our length of stay. Clearly, if you look at patients with a similar, let's say, general medical diagnosis like pneumonia, their length of stay is going to be shorter if they go home with or without services as compared to if they go to a post-acute facility. And part of that is simply related to the challenge of finding a bed and getting it approved by the insurer and all of those things. And our patients want to go home, and we want to get them there. And if we can do that without having them stop someplace in the middle, that we feel is a good way to go. So let's take a moment to just sort of talk about what we're doing here at Maine Medical Center for early mobilization. And I think it's fair to say that we have imbibed the Kool-Aid here. We believe the science that this is a really, really important thing for all of our patients. And so our nursing colleagues in particular really have embraced this concept of mobilization for all of our patients to the extent that it's possible. And the way that that is accomplished is that the nursing and therapy teams collaborate in developing a mobility plan for every patient. And, for some of them, that may be sitting up in bed to eat a meal or getting to a bedside chair. It's going to be highly dependent on what their physical issues are. But that plan is developed for every patient. And then to keep our feet to the fire a little bit, the mobility goals, or I should say the achievement of mobility goals, are a key performance indicator for many of our nursing units. So that, really keeps people focused on the importance of getting this accomplished. And then I want to spend a minute or two talking about our enhanced therapy pathway. This initially developed at the early on in the pandemic, where I'm sure people can remember there was a time where it was close to impossible to discharge a patient to post-acute care, either because facilities were closed because of COVID outbreaks, beds were closed because of lack of staffing. And we just, our throughput sort of ground to a halt. And we said, if we can't provide rehab services after the hospital, well, we're going to have to do it here so that we can actually get these folks safely home. So, this program was developed in close collaboration with our rehab partners. And as the service currently stands, this is a small service in a large hospital. So at any given time, there are typically about 6 people on the enhanced therapy pathway right now, and typically they are on that pathway for about 2 weeks. Now, a lot of our folks will be able to discharge home before that 2-week mark, but folks can't stay on the service forever because it's so constrained. So they get their 2 weeks, and then if they have not been able to progress to a discharge home, we're going to see if we can come up with another plan. And right now, for the most part, this service is reserved for patients who we know need rehab, but may have certain behavioral or payer issues or those kinds of things which make them unable to get to a post-acute rehab bed. In the future, we definitely, we've seen the success of this program, and we would love to be able to expand it further. And that's, we hope as we can develop more data with our work with our friends at Radial, that this will make people realize that expanding those services is a good idea. Next slide. All right, so let's talk a little bit about our collaboration. As Anant sort of laid out for you, the underlying questions that we wanted to try to answer was, can an AI tool help us to prioritize patients, not only for early mobilization, but also really who may be more appropriate to discharge home as opposed to discharging to a post-acute care facility. And in so doing, as we mentioned, typically folks that are going home have a shorter length of stay. So in so doing, the hope would be that we could also improve hospital throughput and get more folks appropriately directly home. So the way that this is working for us right now, we're roughly about 6 months into our collaboration with Radial, or being live with their product. We're years into collaboration, but it took a while to get things through our IT folks. About 6 months into implementation, and the intent was to have 1 or 2 sort of identified users within care management who could use the product and then communicate with teams about sort of the product output. As it's turning out, I talked about folks being pulled in a lot of directions. And the primary radial user right now is me. But we, in our consulting work that I mentioned, there's a whole area on post-acute care. And as that is developing, our hope is that we will identify a resource within care management who will be the primary user. But what I do in the morning is I open up the Radial product. I look at the list of identified patients, and then I look at the patients. And if I agree that this looks like someone who has a good chance of getting home, I will communicate. We're an Epic shop, so I will communicate with a secure chat with the inpatient care team we sort of have a standard template that says this looks like somebody who might be good to go home, and then I will include particular data points from the Radial output, and I think we'll see some of that on the next slide. One more or not. Yeah, perfect. So yeah, we I think just reflections on kind of our early process that certainly really sort of education and buy-in from the nursing and therapy teams has been very important in this process. I will say that generally speaking, the reception of these smart placement Epic chats, the teams really seem to be very receptive to the recommendations. And then, the Epic chat that we send also not only talks about the possibility of patients going home, but is sort of a reminder of, oh, by the way, mobilizing this patient early will hopefully help in achieving that goal of getting home. So while I said that we're trying to mobilize everybody early here that we can, we understand the reality of a busy hospital. And so maybe this message helps to sort of bubble those folks up to the top in the mobilization strategy. So we're gonna run through a couple of cases which we've made intentionally a little bit vague, but this is kind of from our experience working with Radial. And this is a 94-year-old man who was hospitalized after an episode of unresponsiveness. He presented to the emergency department from home for evaluation. And some of the sort of output from Radial, you can see here. It tells us that the last hospital stay was a year ago, and that the most recent admission resulted in a discharge home with no 30-day readmission, and that the patient had not been hospitalized in the last year. The other kind of nice piece of output is that there's feedback about how consistently this patient has followed up with their primary care physician and various specialists, which is not always, readily available to a hospitalist or somebody who's taking care of patients in the hospital. And so we sent our message out to the team, and they worked on mobilizing the patient. You can see that they saw a few specialists that they needed to see, and therapy did agree that discharge home sounded like a good plan. And after a 4-day stay, the patient was able to discharge home. So these are, the kind of success stories. And, I think there's any hospitalists on the line, when you admit a 94-year-old patient sort of right out of the gates, you're going to probably say, wow, I wonder if this person's going to need rehab. But this is a nice successful story, and we've got one other to review with you, and that was a 78-year-old man who was admitted to the hospital, identified as Radial as a good potential patient to go home. And interestingly, when I reviewed the case, there was a discrepant recommendation from our therapy colleagues. So, and I'm sure that you've seen this before. So the physical therapist was recommending a skilled stay post-rehab, but the occupational therapist thought that the patient could probably succeed well at home based on some of the help that they already had established in the home setting. So I sent my message to the team, and I specifically called out the discrepancy in those recommendations. And essentially the outcome of that was the teams, everybody put their heads together and agreed that a discharge home as this patient was progressing through their hospital stay looked possible, and they were able to discharge home without going to a post-acute care facility. And then, Anant referenced some of the savings, and, of course, this is an important thing for us to think about as hospitals and health systems. The difference between sending somebody to an acute rehab and a home with services is around $20,000. Now, granted, a lot of folks that are going to go to an acute rehab probably need to be there. You might sort of make that argument, and really the collaboration with Radial, probably the sweet spot is a little bit more in identifying patients who are kind of on the fence between a skilled facility and going home. But even there, it's a potential for essentially $10,000 savings for the ACO. And I mentioned in the beginning that our ACO membership is about 300,000 lives. So, the estimate for the main health ACO is the potential for savings of around $2.5 million a year by directing folks to, the place which is really clinically most appropriate for them. So that, that is an important thing to think about when we're trying to talk to our finance folks about whether or not they will finance these kinds of collaborations. Next slide. Great. So we really appreciate your attention today. We're going to just sort of bring it around a little bit to lessons learned, and then we will, looks like, have a couple of minutes for questions in case anyone has any. So as I said, our early experience, we have seen encouraging results in terms of identifying these patients, these on-the-border patients, working with the teams and thinking about a home plan. It has definitely been, I think, most effective for us when we can identify these patients prior to their having been involved with therapy. Our therapy colleagues are fantastic. They're also relatively conservative. And I think that, once they've made a recommendation for a patient to go to rehab, that is generally what the care team is going to say. Well, they're the specialists and they said the patient needs to go to rehab, so they're going to rehab. So planting that seed for the therapy team ahead of time, giving them that data from the Radial output has definitely been useful. And then, we did struggle a little bit in the beginning, I think, when we didn't have really identified dedicated staff to do this work every day, get the communications out to the team. And I think that now that we have done that, it really has been more effective for us. And so future directions, certainly as Anant talked about, the whether you're going home or whether you're going to rehab is a piece of the pie of value-based care. And there are other things to think about in terms of palliative care, end-of-life care, and some of the things that he outlined in the beginning of the talk. So certainly the potential to, apply this work to other areas in the spectrum of value-based care. And I believe that is our last slide. So thank you so much for your attention today. And as we said, we'd be happy to answer questions. It looks like I see a few in the Q&A. And so one is Maine Health planning on, doing its own outcome study or ROI study after a year or so. So absolutely. And there are reporting capabilities that are built into the Radial product, and Anand can speak more eloquently to that than I can, but we absolutely are planning on looking at that.
Yeah, and one thing I could just mention from the perspective of outcomes and ROI is specifically thinking about this placement product that we've deployed across many different ACOs. We looked at three specific outcomes metrics that have pretty consistently shown the same thing. The first is a decrease in patients going to skilled nursing facility and commensurate increase in patients going to home with services. But then on the back end, thinking about quality, we track 30-day readmissions, and we've actually fairly consistently seen a decrease in readmission rates. And I think this is just a reflection of the fact that if the right patients to go home are actually sent to a facility, they can have some of the adverse outcomes that we'd previously mentioned. And we also have tracked inpatient length of stay and have seen a trend towards a decrease in inpatient length of stay. And Chris had mentioned, kind of a similar intuition around patients waiting for rehab beds in the inpatient setting and that increasing length of stay. The final thing I'll just mention in terms of ROI is that we've pretty consistently seen something around a 5 or more to 1 ROI across deployments of specifically our placement module.
But then the next question is data heavy, so I'm gonna let you go with that too.
Okay, so the question is that claims data is needed, but how hard is it to get the comprehensive claims? So, yes. So these are this is a good question. So the way in which we usually approach this is when we work with our ACO partners. Our ACO partners typically pass through the CCLF files, the claims data, and we typically rely on at least a year or more, often multiple years of this claims data, just to build some of that longitudinal context and clinical, functional, and social risk profile. And this, it's so critical to have that fundamental context when we're trying to figure out whether this specific hospitalization that's ongoing is an aberration compared to some of the long-term trends, whether it's a continuation, whether it's an acceleration or escalation of bad trends. And so that context really helps sort of provide that. So generally, we've not had any difficulty with our ACO partners passing through the comprehensive claims. But as you know, the claims there's a claims lag, and that reconciliation can be even 90 days in many cases. And so we're also leveraging, just as you're saying, some real-time information. So that's typically a combination of HL7 ADT feeds, plugging into health information exchange data. There are many state-based HIEs, but we also work with other HIEs across the country. And so really the combination of the two really seems to power our interpretation of what's driving the current hospitalization and whether or not it's safe to get them home.
Okay, well, I think we are at time. Thank you so much, Anna and Chris, for this presentation. This was actually excellent. And if there are no other questions, I would like to thank everybody for joining us for today's Himss webinar presented by our premier sponsor, Radial Analytics. So please give us your feedback as you exit today's session. The recording will also be posted on our Himss YouTube channel, and you will receive both a copy of the PDF of today's presentation as well as the CP Himss credit via email tomorrow. So thank you all very much for joining us. Wishing you all a very happy and healthy holiday season. Have a great day. Thank you.
Thank you all.